Hey guys, Michael here, and this is a video on arterial blood gas interpretation. Now, arterial blood gas analysis is a blood test that measures the acidity or pH levels of oxygen and carbon dioxide. These results provide important clinical information for patients with respiratory disorders, compromised circulation, or abnormal metabolism. Now, common indications for the use of an ABG include issues with lung function, kidney function, patients presenting in shock, post-trauma, with uncontrolled diabetes, in asthma exacerbation or exacerbation of COPD, patients that have experienced a drug overdose or are experiencing metabolic disease, chemical poisoning, or current infection or sepsis. Now, whilst there are no actual contraindications for the procedure of performing an ABG, it must be remembered that this procedure is invasive, and so judgment must be used as the appropriateness of performing the procedure in the pre-hospital setting. Contraindications of the use of a specific site, however, may include occlusion of the vasculature previous to your attempts of artery puncture, infection, the inability to compress the site after you've performed arterial puncture, and signs of a lack of collateral circulation to the distal tissue. There are a few complications that might occur when performing an ABG. You may inadvertently cause an embolism, a hematoma, hemorrhaging, bleeding, a thrombosis, or infection at the site of puncture. You've also got to remember that there are a number of safety considerations for this procedure. There is a high likelihood of exposure to blood. You've got to make sure you're wearing appropriate PPE, discarding soiled items appropriately to clinical waste, and with the use of sharps, you want to make sure that you're using safe handlings of sharps at all times and disposing of the sharps into an appropriate sharps container. Now, key points for documentation of an arterial blood gas analysis. You want to make sure that you're writing down the indication for the procedure, the time that the procedure was performed, and quite importantly, the location that you performed the procedure, whether it was a right or left radial artery, or perhaps an artery somewhere else on the body. This is to ensure that down the track, these sites can be monitored for signs of infection or occlusion or any other issues. And this is also something you need to note down if there are any future complications at all. Another pretty important one is to make sure that you write down or record the results of the actual blood analysis itself. Now, the equipment that is required for an ABG analysis, you're going to need your personal protective equipment, gloves, goggles, hand sanitizer, face mask if necessary, a needle, generally a small one, about 23 gauge, an ABG 2mm syringe, plus or minus heparin, depending on the manufacturer's specifications. You'll need a cap for the syringe, a plastic bung, local anesthetic if that's decreed by your local service, an alcohol swab, gauze, tape, a sharps bin, and for this demonstration, an iStat machine and a cartridge for the iStat machine. Now, to perform the analysis of the blood, you also need to collect the sample. So we're going to press the on-off key to turn the iStat on. We're then going to select the appropriate ABG analysis cartridge. We're using the iStat machine. We're either going to scan or enter the relevant operator ID, enter the patient ID, and then scan the barcode on the cartridge pouch. Avoid touching the white label or electrode whilst doing this. So we're going to locate our chosen site for arterial puncture to collect our sample. So once we've chosen our site, which would either be the radial, brachial, or femoral artery, we are then going to insert the needle at an approximate 30-degree angle to the skin at the point of maximum pulsation of the artery that can be palpated with the fingers. We're going to advance the needle until arterial blood flushes into the syringe. Now, once an adequate sample has been collected, we want to remove the syringe, place the needle into the sharps bin, and recap the syringe. We want to make sure that we're applying firm pressure over the puncture site with gauze to stop bleeding, and we want to hold this until bleeding ceases, and this may be up to 5 minutes, seeing as it is an arterial bleed. We then want to apply a clean gauze and hold it down with tape. Now, the sample that is in the syringe, we want to mix it vigorously by rolling the syringe between the palms of your hands for 5 seconds, inverting it and then repeating, rolling for another 5 seconds. We then want to discard the first 3 drops of blood from the syringe before putting the ABG syringe tip into the cartridge sample well of the iStat. Now we want to dispense the desired amount of blood into the cartridge, until it reaches the fill mark and the well is half full. We immediately close the cover over the sample well until it snaps into place. We can then insert the cartridge into the port on the iStat, and that'll have another click when it's fully in place. And then the iStat will go to work and do the analysis. And at the end of the countdown, the results will be displayed on the display screen. Now, a quick overview of the pieces of information that the ABG will show you. Now, the pH refers to hydrogen ions. It's the concentration of hydrogen ions. The presence of or the lack of too many or too little will tell you if the patient is acidotic or alkalotic. The value for this is normally between 7.35 to 7.45. The base excess or base deficit represents an increase or decrease in the amount of base present compared with the amount of acid present. So this is usually plus or minus 2, and that's the range in millimoles per litre. Your HCO3 minus, your hydrogen carbonate, is a concentration of hydrogen carbonate in the blood. That's between 22 to 26 millimoles per litre. The partial pressure of carbon dioxide reflects alveolar ventilation as it diffuses across the alveolar capillary membrane and is blown off. So this is your expired carbon dioxide. This is between 35 and 45 millimeters of mercury. The partial pressure of oxygen is your arterial oxygen tension, your PaO2. This is between 75 and 100 milligrams of mercury. Your lactate or lactic acid. Now, when the cells no longer have enough oxygen for normal metabolism, anaerobic metabolism takes over, resulting in lactate production, leading to lactic acidosis. Now, a normal range for this is between 0.5 and 2 millimoles per litre. And finally, your HB or hemoglobin is the amount of hemoglobin in the blood possibly capable of carrying oxygen, normally between 135 and 180 grams per litre. Now, before I start with the interpretation of ABG results, I just have to say that full credit for the following flowcharts go to Chinoa Crimes from Workgroup 6, as she's produced these for our group, and they are fantastic pieces of reference for us. Now, when interpreting the pH, the first thing to look at, or an ABG rather, is to look at the pH. Now, if the pH is below 7.35, the patient is acidotic. If the pH is above 7.45, the patient is in alkalosis. And if it's between the 7.35 to 7.45, then that patient is within the normal range. There's no abnormality or mixed acid-base disorder happening currently. Now, if the pH is low, patient is acidotic. Now, if that acidotic patient has a high PCO2, then they are in respiratory acidosis. Conversely, if they have a low HCO3, they are in metabolic acidosis. On the flip side, if they have a high pH and have a low PCO2, then they're in respiratory alkalosis. If they have a high pH and have high HCO3, then they're in metabolic alkalosis. So it's important to look at that PCO2 is very important to differentiating between respiratory acidosis and alkalosis, whilst HCO3 differentiates between metabolic acidosis and alkalosis. Now that we've figured out whether or not the patient is in respiratory or metabolic acidosis or alkalosis, we need to try and figure out whether the body is compensating for this change. For example, a patient in respiratory acidosis with increased PCO2, if they have an increase in HCO3, then this patient is in respiratory acidosis with metabolic compensation. Now, if that patient has a normal pH with a high PCO2 and a high HCO3 minus, then we say that that patient has fully compensated. If the patient still has a low pH with an increase in HCO3 as well, then they're in a partial attempt to compensate to help normalize that pH. Now the same can be applied to the rest of metabolic acidosis and respiratory and metabolic alkalosis, with the inverse change from the body system that hasn't been affected, and that's how we figure out whether compensation has occurred. Thanks for listening to my video on simple ABG interpretation. Thanks guys.